Thank you, Sigurd, very much for this nice introduction. Thanks to the organizers for inviting me to this 20 years jubilee of Alzheimer Europe. And I must say that Alzheimer Europe are really contributing to both the quality of our patients and our caregivers, and certainly also supporting us in the more academic research part. I'll give you mainly a view on development of pharmaceutical drugs treatment for Alzheimer's disease, but I'll start with a short background. As you know, it's more than 100 years ago now that Alois Alzheimer, the German psychiatrist, he was psychiatrist, neurologist, and pathologist on the same time, I would say, followed a patient over 5 years until she died, and then at autopsy, he showed these changes I've depicted on this slide. The brownish are the senile plaques, and the black ones inside the nerve cells are the neurofibrillary tangles. And not very much happened during the coming 80 years, but during the last, I would say, 20 years, we have seen an explosion of ideas to develop new pharmaceutical drugs that could interfere in the production of these senile plaques and the neurofibrillary tangles. I'll give you some thoughts about that. In the senile plaques, the central part consists, I would say, to 100% of beta amyloid. And many believe that the beta amyloid is the main toxic part causing the nerve cell deaths, the too early nerve cell deaths, I would say, in the disease. But also the neurofibrillary tangles, who are located inside the nerve cells, they hinder the transportation of the neurotransmitters down to the nerve endings, or the synapses as we call it. And from autopsy studies, the neuropathologists have shown that the primary lesion is probably in these synapses, in the nerve endings. So much focus, I think, in the future also concerning new treatment strategies will be to preserve the synaptic loss in this disease. European epidemiological studies are really contributing to a better understanding about risk factors and protective factors for the disease. And of course, if we are designing prevention studies, we have learned a lot from these longitudinal epidemiological studies. And you can see that I have depicted some non-modifiable factors, risk factors, and some modifiable factors at the bottom. And if we look on the non-modifiable, we can realize that we cannot do much to the age or the genetic changes we have, the mutations we have heard about. But we can do very much for affecting the risk factors that you see down to the right. Risk factors like having high cholesterol levels in blood, being obese, having diabetes or even pre-diabetes. And to the left, you can see that we can almost reduce the total increased risk by treating individuals who have a high blood pressure in midlife for the increased risk to getting dementia and Alzheimer's disease when they get older, if we treat those patients with antihypertensive drugs. And the same seems to be true for the lipid-lowering drugs. So I think the GPs will play a very important role in the future by really early in life treat patients very actively against the risk factors. And these risk factors, in a way, are the same risk factors as we see cause cardiovascular problems. So if we can, let's say, save the heart, then we can also save the brain in a nice way. If we look on the key domains where we are looking to improving the patient's situation, it's of course cognition is the primary thing. If we can, with training or with drugs, influence and improve the memory function, then we gain a lot, I think. And I think also that cognition, in a way, drives the activities of daily living, the communication, and much of the social and behavioral symptoms we see in our patients. So these are 4 key domains that we look to when we look if we have a positive effect in any of the treatment strategies we are using. I listened yesterday to the symposium about nursing home care, and I summarized a little what I think characterizes a good care. And I must say that the most direct effect and the most positive effect we have had about the intense research being done the last 20 years is that we have improved the quality of care for the patient. So, I mean, the nursing, the social part, there we have gained a lot. Still, we don't have, with molecules of pharma, we cannot cure the disease, but we can certainly have a symptomatic effect, and I'll come back to that later. But if I conclude what we heard yesterday, I think both the environmental part and the staff are of great importance. And we, of course, need a good and friendly environment, not a stressful environment for our patients. We also, as said, need a proper competence of the staff. And the staff members should have a high, I would say, also medical and social competence. It's important, for example, as I see in these new types of living, that we have nurses in these settings. The staff also have to think diagnostic and prognostic, so they can avoid that bad things are happening. I mean, if a patient wake up and is very anxious, nervous, aggressive, of course, he might have had a bad night's sleep, and then you could care for that in a good way. What you also see in our wards are that we have a high turnover of staff, and I think it's important that we try to keep a staff continuity, and of course also the unit leaders are of great importance, that the unit leaders are much engaged and knowledgeable, and of course we have to meet the basic needs of the patients. Plausible staffing, I mentioned, and flexible routines, and we heard much yesterday about a person-centered care, and of course an individualized care is of greatest importance. And this also relates that we have to have in the institution type of care we see in Europe, we have to have a good care philosophy. If I now move over to the main part of my talk, which will be the pharmacological treatment strategies, we see here that we have 4 drugs approved on the market. The first 3 to the left, Aricept, Exel, and Remenil, are all working on the acetylcholinergic system, improving that system. And the last, Memantine or Ibixa, that is approved in Europe for moderate and severe Alzheimer's disease, worked on the glutamatergic system. Of course, as we heard by the first speaker today, drug companies now are really focusing on having disease-modifying treatments, really affecting the underlying primary pathology. Still, I must say, involvement is occurring also with these drugs. We can see that rivastigmine, for example, now we have a patch formulation, and for Memantine recently, once daily formulation was introduced. This is the idea to give a patch. The big international multicenter studies showed that rivastigmine in patches have the same positive effects on the patients, but much fewer side effects. I mean, you could almost avoid the gastrointestinal side effects by giving the patch. The drug goes through the skin, it's a bit lipophilic, directly into the blood and up to the brain, and not needs to pass the gastrointestinal and liver passage. Relatives were also very positive to it, and it was a visible proof that their relatives had taken the medication. Another idea coming up is, can we combine these drugs? And more it turns up that combination of drugs, let's say giving a cocktail of drugs, would be another approach. And the first combination that was proven to be effective was the combination of cholinergic drugs with Memantine. And on this slide you can see that The lowest line is when you have no drug, then you can see that the time for nursing home admission, if you look on follow-up times at the bottom, you can see 7.5 years, and then almost 80% of the individuals after 7.5 years have moved from home to some institutional care. If you look on the red graph, that's using the cholinergic drugs alone, then you can see that after 7.5 years, almost 40% or 35% have moved to nursing home. But if you have the green line, the combination of memantine plus a cholinesterase inhibitor, then you can see that much fewer people move to nursing home. And this, of course, is positive both for the patients, hopefully for the caregivers, but certainly from a societal perspective, from a health economic perspective, it's very important. If you look for future treatment strategies, where does the basic research lead us? And I mentioned that the A-beta pathology is a key target for many of our drug trials, and I'll show you a slide later how many drugs are tested just now. Tau pathology, I mentioned, there are fewer trials ongoing affecting the tau phosphorylation or the tau aggregation. And concerning reducing cholesterol level, I must say that it's only a few studies and some have been reported not too positive, I would say. And there are certainly all and many other strategies. One other strategy was the introduction of a Russian anti-allergic drug called Dilibon, and in a Russian study, this is the publication of that Russian study where Rachel Doody was the principal investigator, and she published it in Lancet in 2008. And you can see those that were actively treating are the green line. And after 1 year, 52 weeks treatment, they were actually producing a bit better than they were at the start of the study. While those that were on placebo, the more blue line, they declined over 52 weeks. And there was an increasing difference between those that were on active and those that were on passive treatment. And this increasing difference could be indication. We heard from the first speaker about slope analysis. And when we see that the curves are divergent, this could indicate that the drug affects the underlying pathology. However, a recent study, there was a press release in spring this year, showed that the follow-up study was not significantly positive, but in that study, they could not reproduce that the placebo patients were declining, and that study was only performed over 6 months. So I think it was a too short study time really to draw conclusive results from that study, I would say. Yeah, I've had a lot of problems this morning with the slides, I'm sorry. This slide, yeah, it doesn't look much. It should show what is the idea now about Dilibon's effect. It's actually an idea that Dilibons affect the synapses. It affects the mitochondria. The mitochondria are the atomic energy supply in our cells. I mean, they produce the ATP, what the cell is dependent on to survive. And Dilibon, as we see it in experiments in the lab, really change and increase the membrane potential of these mitochondria, and it also increases the ATP production. So with Dilibon, the idea here, we move away from like the cholinergic drugs to affect one transmitter. We move away to affect a part of the cell, a cell organelle, the mitochondria. And I think that's a new approach that looks very interesting. So we'll see what the ongoing European study will give. It's an ongoing study where the last patients will be including the coming months, and I do hope that we might have in a years' time or more some positive results. Much hope is also put to the idea of immunotherapy, vaccination. Of course, when we hear the word vaccination, we think about viruses, bacteria, or fungi. But this was actually an idea that if we could take this beta amyloid that form the senile plaque, inject it into human beings, they would produce antibodies that would, from the immune system, go up into the brain and clear out the amyloid that would be the toxic part. Unfortunately, the first study was negative in that respect, that we saw too much side effects. Now people went back to the laboratories and they developed the second alternative here. You see this round circle with the blue fragments, A-beta fragments on, and the fragments are only the first 6 amino acids in the A-beta 42 molecule. And if you inject that then subcutaneously or intramuscular, the patients develop their antibodies, they go up into the brain, and they might clear out the A-beta part that is the toxic part. And this approach has now been taken, and I'll give you some preliminary results from these studies. The third paragraph here is the passive immunization, and that is that antibodies are formed outside the human being. They are usually formed in animals. They are humanized and then injected intravenously. And then you have started to do the injections, for example, every second week or every fourth week, the rest of your life. Very large studies with these passive immunization are ongoing, and we can expect the first result in 2012. Then we will have the phase 3 data on 1,200 patients being in that study. So we really look forward to what the results are. And from the first preliminary studies, we can say that the results support really to go on in a big phase 3 trial. To give these passive antibodies to the patients, it seemed to be safe. There were some side effects. They have some swelling around the vessels, especially in patients that were ApoE4 positive carriers, we could say. And when they did a post hoc analysis, an analysis where they separated patients that either had this ApoE4 allele or not, then there was a trend saying that those who did not have it had reacted more positively, giving a positive answer, I would say, on cognitive endpoints and on functional endpoints. So this led the company to now move over into multinational, multi-center phase 3 trials that will be ready, as I said, in 2012. The active approach with this small round biosphere you saw on the earlier slide, with the small fragments attached to that via a linker arm, this biosphere in the middle that really stimulates the patient's immune system so they can produce more antibodies. And we have been running these first studies. This is a Novartis-sponsored trial with different dosages, and I can say that it is possible to see that with the active approach, we induce A-beta-specific IgG antibodies. And just now, studies are ongoing to find the right doses for vaccination, the right how many times you have to give the vaccination, and after that, it will be moved over, hopefully in phase 3 trials for approval, as we heard. I summarized also some advantages and disadvantages with this immunotherapy. If we look on the passive immunization, where we have to give antibodies regularly the rest of your life, then it's of course easy. If you see side effects, it's easier to stop the study. And it's also possible to design these antibodies so they are very, very specific against the beta amyloid we want to take away from the brain. whether this is shorter or longer parts of that molecule. The disadvantages, as said, is that you have to have lifelong injections and mostly intravenous. And of course, if you want to move this out into the GP level, it is a problem. And I mentioned the side effects at the bottom. The active immunization advantage is fewer visits, less costly, and a constant antibody production. Disadvantage is certainly also we have seen rather much of local skin reactions. Concerning tau as a target, you might have heard about the Scottish studies where they used a dye. It's called methylthioneum chloride, REMBER. I have heard now that they are out in phase 3 studies, but I have no data to present for you. If you look on more visionary treatment strategies, you hear about in the press about stem cells, you hear in the press about nerve growth factors. And this slide just shows a study we have just finalized at our hospital. It's a phase 1b study where we implant catheters into the brain, and where in the tip of the catheter we have introduced cells that are producing nerve growth factors. So we have done that on 6 patients, and so far they have had it for 1 year, and 2 out of these 6 patients has improved on cognitive tests. We can also see in the positron emission tomography upregulation in the cholinergic system, and we can see that they, as said, produce better on some of the neuropsychological tests. It's of course an experimental proof if nerve growth factor therapy would be a way to continue. Then, of course, we have to find new ways of administration. The disadvantage is that nerve growth factor does not pass the blood-brain barrier. That's why we have to give it directly into the brain of the patients. These slides could look very, I would say, busy, but for me it gives a lot of hope. It's from a publication that we did recently in Lancet Neurology. Francesca Mangialasce from Perugia is the main author. And you can see those to the left that are in red. All these molecules are in clinical trials and to test the amyloid idea. And some of these in phase 3, if you can see the phases, phase 1, 2, 3, are those with antibodies and bapineuzumab, solanezumab. It's difficult because I cannot point. Sorry for that. Those up to the right in blue, that are molecules that are testing to affect the tau phosphorylation, tau aggregation that is occurring intracellular. And those in green, and you can see in phase 3, for example, Dilibon, statins, those are drugs with other modes of action. But this is roughly what I could find ongoing in clinical trials, and then you can understand the interest in the area, and that I'm sure that these trials will in a very soon future give us good ideas how to continue, and hopefully some drugs that could be approved by our authorities for the indication disease modification of these diseases. So if I come to conclude this, I can say that this is a multifactorial disease. There is a need, as we have heard, for disease-modifying drugs, perhaps with different modes of action, but also individualized treatment strategies, affecting A-beta, tau, ApoE, cholesterol, oxidative stress, inflammation, etc. And we also heard that the authorities really are positive to more early diagnostic tools and biomarkers. Philippe Amiel showed us also one of the ideas for a program in this was to standardize the CSF assembly. This is how we do it in sitting position with a well-defined needle, etc. And in a Swedish project, we have followed 1,200 individuals that we have CSF tapped over time. And if you look on the left panel only, you can see that we have depicted beta amyloid on the y-axis, A beta 42, and on the x-axis, the CSF tau levels. And those that are in red, those have low A beta and high CSF in their cerebrospinal fluid. And when we follow those for 2 years, almost all of them convert or continue into Alzheimer's disease, while those having high tau and low tau and high A beta, they are stable and will not continue into the more advanced stage of the disease. So biomarkers in our hands is a good possibility, helping in diagnosis, but also as an outcome in the clinical trials. Another interesting field is the PET scanning. In the bottom, you can see we have looked on patients having this condition, MCI, and then followed these for 2 years. And then we saw half of the patients developed Alzheimer's disease, half were remaining or being like healthy controls. And when we went back and looked on how they looked, we could see that those that converted to Alzheimer's disease, those already at start had a pattern with red and yellow in cortical areas, indicating that they already then had the Alzheimer pathology in their brains. So to summarize my talk, thinking about prevention, I think we have to have more knowledge about risk and protective factors. I think Europe is really in the lead in this field. We should develop drugs. We should understand more. The basic research should give us more ideas about better targets affecting the disease mechanism. I think for us working in clinical work, a combination certainly of prevention, drug treatment, and good care is the optimal situation. And as we have heard from our authorities, are really trying to reduce the gap between what we know from research and what we do in our clinical work. I also want to remind you on a conference that we are organizing in London. It's the 6th International Pharmacoeconomic Conference. Much of what we do is always certainly evaluated in monetary terms, and I think that we also from the clinical side have to look on what are the costs, what are the outcomes, and put that in some relation. Thank you.